This program is brought to you by Emory University.
There's sort of a unique presentation today that the fellows put together. We have the interventional fellows are fantastic, and 4 of them put together this talk on some of the cutting edge things that we're doing in interventional cardiology with some changes in revascularization strategies and thought processes. And Eric Shin's going to kind of lead the charge, but Eric's going to stay with us next year and do structural with Vasilis and Adam and the guys. And then we have Leah Raj, who's going to be one of our first CHIP fellows next year. She's excellent. And then along with that, Pratik Sandesara is going to be our other CHIP fellow next year. And then Ayman Tahhan's going into practice, and Ayman's a brilliant operator, brilliant guy, and is going to be very successful. So they put together a really nice talk, kind of goes through some of the changes in strategies and sort of the controversy around some of it, and have a little bit of audience participation. Hopefully it's case-based, and I'm going to let I don't know who's starting. I think Eric's going to take the lead on things, so I'm going to kind of turn it over to him if that's the case.
Okay, thank you, Dr. Nicholson, and thank you, Dr. Mehta, for giving us the opportunity to present our discussion today. Our talk is titled Percutaneous Intervention for High-Risk Coronary Anatomy, When to Proceed and How to Succeed. This is a case-based presentation that we'll share, and hopefully you'll understand what it's like to be a day in the life of one of the interventional fellows. As I mentioned, we do encourage audience participation. So if you could take a minute to type this into your web browser. We have some polls for each of the cases that we would like you to vote on. Once you log in, just wait on the questions to come up, and then when the questions, just select your one best answer. I'll give everyone a chance to log in there. Okay, so the learning objectives for this talk include understanding the evidence behind the recommendations for PCI or CABG during a heart team discussion for patients with high-risk coronary anatomy. 2, understand how the syntax score assesses technical difficulty and informs pre-procedural planning prior to PCI. 3, understand how contemporary tools and techniques enable intervention on complex lesions. And 4, be familiar with some quality improvement initiatives currently in place to minimize complications from PCI. This talk is highly founded on the appropriate use criteria published from 2017 that specifically looks at the recommendations for revascularization to improve survival compared to medical therapy, which is a different concept than revascularization to improve angina. But our talk is based on these recommendations. And so you'll see any patient with complex CAD, whether that be unprotected left main or multiple vessel disease, it's always a class 1 recommendation to pursue a heart team approach. You have local experts, national experts who are the leaders in their field in both surgery and PCI. And so you should always seek to understand the opinions of these team members when you recommend someone for revascularization. You'll also see that for all patients that it is recommended to calculate a STS and a syntax score, which are our 2 tools that help stratify patients for their risk of surgery and PCI respectively. As many of you are probably familiar with and have used in numerous times, the ST score is a Society of Thoracic Surgeons 30-day predicted risk of mortality. It was initially created in the 1990s and used a registry of tens of thousands of patients undergoing CABG, and then ultimately other cardiac surgeries such as valve replacements. This STS score gets validated and recalibrated over time, and basically what it has shown is that it is able to predict mortality after CABG at 30 days and also long term. Here's an example of using the score to split patients into their appropriate deciles, and on the x-axis is the predicted risk, and on the y-axis you have actual risk mortality. So this is a very good tool for predicting mortality for surgery. Now the complement to that is the syntax score, which is specifically for PCI. And what this is it's an angiographic grading tool used to determine the complexity of coronary artery disease. Lower scores are less complex, where we use a cutoff of 23 being low, quote, on low complexity, and higher is more complex, where greater than 32 is high complexity, and anything in between is intermediate. Each significant lesion is graded, and proximal large vessels, such as the left main and proximal LAD, get higher scores than smaller distal vessels. And then you assign additional complexity for lesions that represent chronic total occlusions, branch points or bifurcations, long lesions, vessels that are very tortuous or that are highly calcified. And basically, the concept here is anything that prevents or slows you down from putting a stent with optimal deployment will increase time and the necessity for adjunct tools or planning to successfully perform your PCI. So the first case I want to discuss here is that of multivessel disease, which is defined as 70% or greater stenosis in at least 2 separate epicardial coronary arteries supplying distinct coronary distributions. We started with a case of a 79-year-old male with a recent COVID infection transferred from an outside hospital due to prolonged hospitalization for post-COVID respiratory failure. This patient has been dependent on 4 to 5 liters of oxygen since diagnosis and has developed chronic organizing pneumonia. They were found to have a type 2 MI in the setting of shortness of breath and chest pressure with minimal ambulation just within his room. And he had a left heart cache, which identified 3-vessel coronary artery disease. Now, this patient was unable to tolerate minimal activity due to symptoms and subsequently developed deconditioning and muscle wasting. His post-COVID course has lasted greater than 30 days, and this has led to significant disability. His past medical history is significant additionally for diabetes, hypertension, and prostate cancer. This is his angiogram, and as you'll see here in this LAO cranial view, you have a couple lesions here. One is this mid-shaft left main, which is about 50%, as well as this proximal LAD, which is highly calcified. You can tell that it's highly calcified because you can see the shadow of the vessel even when there is no contrast. Additionally, you can see this high ohm lesion, which has a focal stenosis. And on the right side, on the midsection, you'll see a calcific nodule, as well as a bifurcation lesion at the distal RCA, PDA, PLV junction. Also of note, you can see the calcium of the left coronary system here, so you know that the calcification is severe on the left side. So when we consider whether to recommend this patient for surgery or PCI, we can go through our score indexes. The STS score for risk of mortality is 3.3% in this patient, and a combined morbidity and mortality of 11%. Our cumulative syntax score is 30, which is an intermediate complexity coronary anatomy. And based on the old syntax score, this places PCI as having a less optimal result than CABG. The AUC recommendations for this type of condition, again, recommends CABG as a class 1A recommendation or 2A recommendation if patient has syntax score greater than 22 and who are otherwise good candidates for CABG, whereas they place a 2B recommendation for PCI. So based on these findings, what would you recommend in terms of pursuing revascularization or treatment for this patient? So go ahead and log into this site. We have a couple options listed for you. There is no submit function, so just click on the one best answer and that'll be our result. Looks like the results have stopped changing. And so we have 60% of the audience think we should refer for PCI, 33% have referred for CABG, and 8% for medical management. And then there was a question about LV systolic function. It was normal in this case. Okay, so we have some invited discussants on our talk today, including Dr. Grubb, Dr. Sperling, and Dr. Goyle. I know Dr. Grubb has some time limitation, so I'd like to invite her first to provide her perspective on this this case scenario.
Good morning, Eric, and thank you for including me. This is a great case. These are so challenging. You know, I think that there are two different questions. One, you know, does he have appropriate targets for bypass, and is it feasible? And I would say that on the left side, those look like great targets. On the right side, that's a small PDA that plus minus whether or not we would get a good result. So that's the first question. I think the bigger question of then can we do a CABG is this the right patient for CABG? Even though his STS is only calculated at 3.3%, you describe a patient who has severe pulmonary dysfunction, who is debilitated, he's really not ambulating much. And so what is his rehab potential and the additional insult of surgery? Is he going to recover and be able to go home? And I'm getting a sense from what you described that this is a pretty debilitated patient. And even though I could do CABG, it may not be the right answer.
Okay, thank you for that, that perspective. Dr. Goyle, do you have any other thoughts on this, this situation? Or Dr. Sperling, are you on the line?
Yeah, I'm definitely on. So, Eric, thank you for allowing me to comment on this case. I agree with Dr. Grubb. We need to think about the care of the whole patient and not just the coronary anatomy. Dr. Grubb mentioned what would be the potential for rehab. And what we didn't hear related to this case is what is this patient's current medical therapy? You said they were debilitated and having symptoms with activity. But we certainly would want to be sure they're being treated with as optimal medical therapy as possible. And there is a concept called prehab, which means I think a great thing for this patient is optimal medical therapy. Prehab, they did have a type 2 MI, they'd be eligible for that. Let's see how the patient does, have them followed by their clinical cardiologist, and then make a team decision. You know, you talked about the heart team approach. Hopefully the most important member of the team is the patient themselves. Okay.
Well, okay, thank you for that consideration. So I think that was the general consensus, that this patient is very debilitated and may not have a very good rehab potential. What I omitted from this case is that the patient had surgery recommended prior to transfer, but he had a family member or wife who was in hospice and did not feel like the stress of surgery would be conducive to their current situation. The patient was on some basic medical therapy, but could not tolerate full titration due to some hypotension or orthostatics when they tried to ambulate.
Eric, sorry to interrupt here. Dr. Taylor had a question. Maybe Dr. Grubb can answer this. How does the history of COVID play into the consideration for surgery, given reported post-operative issues with COVID patients?
I think it just even more so says that surgery is probably the wrong answer. We have operated on post-COVID patients. I have so far had 3 that were at least 14 days past their symptoms, young patients who otherwise had very few medical problems. But in this particular patient, that would push me even more to not operate on him.
Great, thank you, Dr. Grubb.
Okay. So despite seems like consensus is to either manage this patient with PCI, but why are the recommendations stated as they were with the class 1 or class 2A for surgery? And these are based on 2 fairly older trials that looked specifically at CABG versus PCI in multivessel disease. The first trial here is called the Freedom Trial. It was published in I believe in 2011 or 2012, and it looked at randomized patients who had diabetes and multivessel disease to CABG versus PCI. As you can see on the Kaplan-Meier curve, that over the long run, which was followed up to 8 years, that there's a significantly improvement in mortality mortality, which is the hard outcome of survival when you refer patients for CABG or PCI. There is a caveat. This study, again, was conducted 10 years ago and doesn't necessarily incorporate some of the routine techniques that we use to optimize and outcomes in PCI. Additionally, the Syntax trial, which is all famed for the validating the Syntax score, looked at multivessel PCI versus CABG in all comers, and they found that that the overall event rate of major adverse cardiac events shown in Figure D is lower in CABG versus PCI. However, mortality, as you can see in Figure A, is not different. Again, this study was published back in 2009 and is not necessarily reflective of contemporary PCI practices. Now, the Syntax trial additionally validated this concept of low, intermediate, and high complexity. As you can see in the three figures here, if you have a low complexity Syntax score, PCI and CABG are really not different in terms of MACE. If you have intermediate, you have a slightly increased higher rate of MACE in PCI compared to CABG, and those with the highest Syntax score had the biggest difference in MACE, PCI versus CABG. Now, there is a lot of criticism in using this in contemporary guidelines because the techniques and technology in PCI has advanced quite a bit since the time that these trials were conducted. This is results from Syntax 2 trial, which is a prospective non-randomized trial that looked specifically at patients who underwent multivessel revascularization with a few additional requirements. One, they used newer generation stents. Two, they routinely used IFR and FFR to determine which vessels actually needed revascularization. Three, they used IVUS to make sure that the results of their stent deployment were optimized. And four, they were performed at centers designated as chronic total occlusion capable centers or PCI centers of excellence. And you can see that the cumulative incidence of MACE was significantly reduced compared to the historical control of the Syntax 1 trial. Additionally, when they did a analysis of patients who underwent multivessel PCI in the Syntax 2 registry compared to the Syntax 1 CABG arm, that there was no difference in MACE for all comers. And so when you calculate a Syntax 2 score, which is an iteration of the Syntax scoring, that the 4-year risk of mortality is considered to be 10% in PCI, whereas it was 17% in CABG. So what are some of these tools that we used in the Syntax 2 trial and also in modern day practice to optimize PCI? Many of you are familiar with FFI and IFR, and you'll see here that the use of these physiologic measurements actually reduced the number of vessels that were revascularized per patient, meaning vessels that didn't require stenting did not get stents, and that instantly reduces your risk of complications. Additionally, the use of IVUS was less than 5% in the Syntax 1 score trial, whereas it was greater than 80% in the Syntax 2 trial. IVUS is an excellent tool because it gives you pretty exact measurements of how big your vessel is and how making sure that your stents are opposed and expanded against a vessel wall. Using angiography is essentially guesstimation in terms of making these millimeter-based measurements. And so by using IVUS, there's real significant data that shows that you reduce your risk of MACE by nearly half. Without IVUS, your risk of MACE is about 6% for things like in-stent thrombosis. You can cut that down to 3% with routine use of IVUS. Again, an underexpanded stent immediately increases your risk for in-stent thrombosis, which is a STEMI equivalent. And so without use of IVUS, you're inviting patients to have that in-stent thrombosis. So our plan for this patient was to proceed with PCI, and our basic plan was to pre-treat heavily calcified LAD with rotational atherectomy. Again, calcium fights your expansion of a stent, And so if you can crack this calcium and allow it to expand, this will give you a better result. The mid-shaft left main and the proximal LAD can be treated as one lesion with one long stent, and that was our strategy. And for the high ohm lesion, we would stent up to the ostium, but not turn it into a true bifurcation lesion. And then finally, we were planning to stage the RCA for a later time. You can see here, we have the long calcified proximal LAD lesion with a syntax score of 10. Remember, 10 is about halfway, gets you halfway out of the low complexity score. And so you want to make sure to address this appropriately. These days, we use a lot of rotational atherectomy, which is basically a diamond-crusted drill bit that allows for basically excavation of your calcium and cracking of the circumferential ring. Again, allows you to balloon expand and expand your stent afterward. That's what this looks like on angiogram. So after we performed rotational atherectomy, we were able to expand the area with the balloon and deploy a stent. Next, we focused on the making sure we address the midshaft left main lesion. It has a syntax score of 10 because it's a very important vessel and you want to get this absolutely right, but it's not necessarily difficult to treat in itself. And so with the combination of pretreatment and use of IVUS, we were able to deploy one long stent from the proximal LAD down to the proximal left main. Again, IVUS helps us size both the proximal LAD and the proximal left main so that we expand the stent appropriate to the size of the vessel for both segments. Next, we focused on the OM1 lesion, and you can see here that the syntax score is very low. And so what we just did here was bring our stent flush up to the ostium and deployed, expanded the stent there. And then this is our RCA, which we saved for a later time. Okay, here I'll pass on the presentation to Ayman.
Eric, how'd the patient do?
Patient is on the floor. They did not get an impressively improved in terms of symptoms, but they are moving from the ICU to the floor and towards rehab. So it was a gradual incremental improvement, but it's still a lot of work to go.
Okay. Hi, everyone. Thanks for joining us today. I will be presenting the next case. I have no disclosure for this talk. These are the objectives of this talk. I'll present a left main case and go over some of the evidence for this type of coronary intervention. So 81-year-old gentleman with multiple comorbid conditions, including coronary disease and PCI in the past, sick sinus syndrome with pacemaker, liver cirrhosis, pulmonary hypertension, on-home oxygen, diabetes, hypertension, obesity, and former smoking history. He presented to a community hospital initially with recurrent typical chest pain episodes and was diagnosed with NSTEMI with peak troponin of 4.6. Workup with coronary angiography showed left main stenosis. At that point, the patient was treated with antiplatelet therapy, nitroglycerin for chest pain, and was started on heparin. Patient was transferred to Emory for further evaluation and management. These are some of his relevant labs showing normal kidney and liver function testing, hemoglobin within normal range, and glycemic control. His ultrasound showed ejection fraction of 40% with global hypokinesis and elevated pulmonary pressures. As you can see, he's on aspirin, clopidogrel, beta blocker, high intensity statin, and some other medications. This is a picture of his angiogram showing unprotected left main bifurcation disease, which is defined when there is a significant stenosis in the left main in the absence of patent bypass graft to the LAD or circ. The cutoff angiographically is about 50% for left main. So we have multiple classification schemes that have been proposed to describe coronary bifurcations. Probably the simplest and most widely used is Medina Classification. This assessed the plaque burden based on the presence or absence of stenosis in the proximal main branch, which is the left main here, the distal main branch, which is the LAD, and the side branch, which is in this case is the circumflex. So in our case, this is a left main bifurcation disease with Medina 111, given all the three branches are involved in this stenosis. The distal LAD and circular patent as well. So the heart team approaches class 1 recommendation per the guidelines. And to best assess the best strategy, we assess anatomical complexity as well as operative risk. So to assess coronary disease complexity, we use syntax score, as Eric described. It's designed to predict outcomes related to the anatomic characteristics of the disease. It's divided into low risk, intermediate, and high risk. In our patient, the syntax score was 23. So the cutoff between low and intermediate is 22. So this is in the intermediate range, but lower part of the intermediate range. Syntax 2 score incorporates some of the other clinical variables to improve the predictive accuracy of syntax 1. This includes age, creatinine, ejection fraction. It does not include diabetes, but include these three clinical variables. And based on the syntax 2 score, the risk of mortality with PCI after 4 years is about 14%, and it's 22% with CABG. For the assessment of surgical risk, the Society of Thoracic Surgeons, or STS score, was developed to predict the preoperative 30-day mortality and morbidity. And as you can see here, our patient has a very high mortality risk of surgery with 18% chance of dying, with 8% chance of renal failure, and 32% risk of long hospital stay. So it's very high risk based on this score. This is a slide showing the main results of 2 contemporary trials comparing PCI with CABG for left main disease. Noble trial enrolled about 1,200 patients with stable coronary disease as well as non-ST elevation acute coronary syndrome, regardless of the syntax score. Excel trial enrolled about 1,900 patients with low to intermediate risk by syntax score. They excluded high syntax score patients. This included patients with stable and unstable angina, but excluded acute myocardial infarction. Both trials randomized patients to PCI versus CABG. Noble trial used a composite endpoint of death, non-procedural MI, repeat revascularization, or stroke. Excel used death, stroke, or myocardial infarction. It did not include the repeat revascularization. And as you can see here, after 5 years, Noble showed that CABG was superior to PCI in regards to the composite endpoint. This was mainly driven by revascularization, but the mortality or stroke was not different between the 2 groups at 5 years. This is the result also of Excel trial that showed that there was no difference in the composite endpoint of death, MI, or stroke based on this result and 5-year follow-up. This is a meta-analysis of all contemporary randomized clinical trials performed investigating the treatment of unprotected left main in the modern era with PCI versus CABG. This shows no significant difference in all-cause mortality based on these trials. All previous studies have been underpowered to examine mortality or other individual endpoints, but this meta-analysis shows the risk of death is very similar between CABG and PCI. Similarly, there's no significant long-term differences between PCI and CABG for cardiac death, for stroke, for MI. However, unplanned revascularization was higher in the PCI group compared to CABG. This is still from the meta-analysis that included all the trials in left main. And based on the totality of evidence, guidelines and appropriate use criteria give 1B recommendation for CABG in all unprotected left main disease, regardless of syntax score. However, PCI recommendation is dependent on disease complexity and syntax score. So PCI gets a 2A recommendation in stable angina if syntax score is low and patient is high surgical risk. Also, PCI gets a 2A recommendation if the patient is presenting with non-ST elevation acute coronary syndrome or STEMI, and if the patient is high operative risk. PCI gets 2B recommendation for stable disease if the syntax score is intermediate and the patient is high surgical risk. And if it's complex disease with high syntax score, then it's a 3B recommendation compared to CABG. European guidelines have similar recommendations with 1A recommendation for CABG regardless of syntax score. PCI gets 1A recommendation for low syntax score, 2A recommendation for intermediate syntax, and a 3B recommendation for high syntax. So based on this, I'm gonna ask the audience to vote on what you think is the best treatment. I'm gonna activate the second case. So you can go to paulev.com/Emory 2021 and vote for this. I'm gonna give you maybe a minute or so to vote on this.
Dr. Goyle, are you there?
Yes, I'm here, Eric.
Okay, while we're voting, could you give us your opinion on how to proceed with this patient?
Sure. So thank you also for inviting me to discuss these cases. I think this is great education for we non-interventional folks to understand the thought processes and how you pull the tools together. So this is great that the fellows pulled this together for us. Regarding the appropriate use criteria, this patient presented with an NSTEMI, and so the appropriate use criteria that you're referring to throughout this talk refer to the stable ischemic heart disease population. There's a separate document for acute coronary syndrome, and for acute coronary syndrome, there would be no question that this would be deemed revascularization procedure. I also want to comment that the tables that you're showing during your talk here, you're showing actually guideline tables. The appropriate use criteria has both guideline tables and it has the appropriate use criteria tables. So the guideline tables are what show, if you could go back to the prior slide that you had on there with that table, it shows the class of recommendation. That's what COR is, and the level of evidence. So that's what the COR is, where they show the 1, 2A, 2B, and 3, class of recommendations. This is technically not the appropriate use criteria ratings themselves. The appropriate use criteria ratings themselves are found further in the document, where they rate procedures as appropriate, maybe appropriate, or rarely appropriate to do. In this case, because this is a patient presenting with an NSTEMI, it is hands down appropriate to revascularize with either approach, PCI or CABG.
Okay, thank you for that, Dr. Grubb. Would you operate on a patient who has a non-STEMI and a left main that isn't necessarily closing up, on the cath table?
Okay, so I guess we have two questions. Would we operate on someone with left main disease who comes in with NSTEMI? The answer is yes. Would I operate on this particular patient? No. The high STS score, home O2 dependence, NASH, and this patient is not a good surgical candidate.
Okay, thank you.
Kendra, this is Abi. I have a question for you. Do our surgical colleagues use any ballpark cut points for decision-making that tip them one way or the other when they're looking at the STS risk score above a certain mortality, above a certain combined mortality morbidity? I know it varies case by case. You can't necessarily quote one number, but is there a ballpark number that sort of gives you the heebie-jeebies when you're thinking, I'm not sure I really want to proceed based on these numbers?
Yeah, I think that most of us think that 10 is almost like prohibitive. The other problem with the STS is there are things that aren't necessarily included. So liver cirrhosis or NASH has just become a variable in the risk calculator. And before, cirrhosis would be something that would cause a surgeon to pause in and of itself. Same with home O2 dependence in an octogenarian. So even if this patient's STS score was 2, but he had this same risk profile as was described, I would be very reluctant to do surgery on this patient. So there's not a specific number. It very much is reliant on the overall picture of the patient. But I think if you get into the range of 8 to 10, we're considering that extremely high to prohibitive risk for CABG.
You're speaking specifically of mortality when you say 8 to 10 ballpark?
Correct, correct. That's really the one we start looking at. The combine of morbidity or mortality is certainly important, but some of those variables, if you, for example, if you calculate a risk score on a patient that's a known end-stage renal disease, that morbidity or mortality number will be higher than you would expect, and they'll still do fine with surgery. So, you know, the biggest number is the mortality number for me.
Thank you.
Okay, sure. And
Thank you
show us
both.
what you did.
So here we proceeded with PCI. Clearly, PCI was the winner with 100% voting. So we proceeded with PCI here after talking to the patient, the heart team, and the interventional team. So given the bifurcation disease involving the left main, we used two-stent technique with IVUS guidance and impella support. This is an angiogram where the impella is in, and you can see the left main disease here. We decided to perform DK crush because of the strong evidence behind it. This is a cartoon showing how we do DK crush technique with double kissing balloon. So we wire both LAD and circumflex. We're pre-dilating the LAD here, pre-dilating the circumflex here. Then the side branch stent is deployed in the circumflex all the way to the left main. And then it's crushed from a balloon from the main branch. Then we go ahead and rewire the side branch. And then we do first kissing balloon inflations to open up the struts and the side branch. And now we're ready to stent the LAD all the way to the left main, followed by proximal optimization technique. And then we rewire the side branch. We do sequential balloon inflations, and then the second kissing balloon inflation. And then we end the procedure with proximal optimization technique. And this shows you the bifurcation stenting, where we get really good results with both vessels open here in the struts. So we pre-dilated both branches here. We wired both, of course. We used the IVUS for vessel sizing and optimization. First stent was deployed in the circumflex and then crushed and rewired again. First kissing balloon inflation is done, followed by stenting in the LAD all the way to the left main. And then proximal optimization technique is done in the left main before rewiring the circumflex. And then a second kissing balloon inflation is done, followed by final proximal optimization technique in the left main with a large balloon. And this is our final results. Here we use 75 cc of contrast and 30 minutes of fluoro time. The entire procedure took about an hour and a half. Patient did okay, was discharged after 72 hours. He's doing well, not having any chest pain at home. Thank you, everyone, and I'll turn it over to Leah, who's going to present the next case.
Thanks, Ayman. Great case. So my case is a 57-year-old female with history of hypertension, hyperlipidemia, coronary artery disease, who is treated with a 3-vessel cabbage, a Lima to her LAD, a vein graft to the OM, and vein graft to the PDA, and multiple PCIs to those vein grafts after, who presented with exertional dyspnea worsening over the past 2 weeks. She underwent a left heart cath at an outside hospital and was referred to Emory for further management. At home, she's on DAPT with aspirin and Plavix, high-intensity statin, 2 anti-anginals, and some antihypertensives. Her most recent echo showed an EF of 65% with normal RV function and trace MR. So these first 2 angiograms here are pictures of her native coronaries. So on the left is her left system. It's an AP cranial view. So you can see her left main has some minimal disease. The prox LAD is diffusely diseased, and there's competitive flow in the mid and distal LAD from the Lima. There's a large diagonal branch that has some moderate diffuse disease. On the right is her native RCA, which is essentially diffusely diseased from the ostium and included in the mid segment with some bridge and collaterals. These 2 images are of her vein grafts. On the left is the vein graft to her distal RCA, which has a couple stents in the body of the vein graft, indicating she's had vein graft disease in the past. And then there's some significant disease of the distal anastomosis site into the RCA. On the right is the vein graft to the OM, which backfills into the circ system. And you can also see a stent in that vein graft. The last shot is her Lima graft without significant disease, and there's competitive flow in the distal LAD, which we saw earlier. So as far as management decisions, we thought the indication for revascularization was her worsening exertional dyspnea. As far as the AUC criteria, it's appropriate based on the stenosis supplies one territory that's not anterior, and she's already on 2 anti-anginal drugs. Her syntax score was 11 based on the fact that it's a dominant RCA. It's a proc CTO with a blunt cap and some bridging collaterals, and then the RCA is diffuse disease. And her STS scores, she had a 2.1 risk of mortality and 10% risk of morbidity or mortality. So I'll stop here and poll the audience on how you would manage this patient. The options are redo cabbage of vein graft PCI, open up her native RCA CTO, or medical management. The link is at the bottom if you didn't see it earlier.
All right, Dr. King, are you there?
Yeah, I'm here.
Could you maybe give us your opinion about what would be the best strategy in helping this patient out long term?
Well, yeah, I'm not completely sure. The vein graft to the right, you know, since you're presenting this as a chip kind of case, the answer is expected to be don't go through the vein graft. But it looked like you had a clear shot, and you wouldn't have to dilate the vein graft to get the right. For the lima is the presence of a functioning lima is usually a pretty strong reason not to do surgery. In general, so I'd rule that out. So I think it's either, and as far as the circumflex graft, I don't recall whether there was something to be done over there. But if we're just talking about the right coronary, I think you could do it through the vein graft without causing trouble to the vein graft. That would be my guess from my cursory look at this case.
Okay. So can I get I guess a volunteer from one of our non-invasive colleagues? Looks like the poll, the audience said 90% would refer for native RCA, CTO, PCI, but is that something that even pops up on your radar for a patient who's had graft fail multiple times?
Yeah, for sure. But explain to me again, we're talking about the right? Is that what we're talking about?
Oh, yes, we're talking about the right, but I was wondering if maybe our non-interventional colleagues, maybe Dr. Williams or Dr. Oguni, is this something that even comes up as a consideration when you come across these patients in clinic?
Hey, Eric, this is Robbie. Thanks for inviting me. Yeah, I think I missed the part, Leah, where you had talked about her medical. I mean, I did sort of think about obviously putting D, medical management. Then I remembered who was giving the talk, and I wanted to be correct in my answer. But right, I would, if I think a trial of medication probably might be another option. Clearly, as you're sort of thinking about this patient on the table of intensifying her medical therapy.
Yeah, she was on 2 anti-anginals, Dr. Williams, and still having exertional dyspnea. All right, I'm going to keep moving given our time. So just a few comments about intervening on native CTOs versus vein grafts. So cabbage patients actually represent a good chunk of our patients who come to the cath lab. They represent about 20% of our patients undergoing PCI. And the reason for that is studies have shown that vein grafts often fail. One study showed 18 months, more than 40% of our patients had vein graft failure. And so over the years, it's become more and more common for interventionalists to intervene on native CTOs. As far as most recent data, when they come to the lab for an intervention, almost 2/3 of the time we intervene on the native coronary versus the vein graft. So when we do that, we have a fairly high success rate, more than 95%. We do use some special equipment we don't use for ordinary PCI, including aggressive guide support and guide extension catheters. We use low profile catheters and generally hydrophilic wires. But we do have serious complications, which do include perforations and peri-procedural MIs. But regardless, vein graft PCI is associated with significant higher mortality, MIs, repeat revascularization, and stent thrombosis. So just going back to her case, given the fact that she had symptoms and failed vein grafts in the past, we elected to perform PCI on the native RCA CTO using what we call an antegrade dissection reentry technique. So we got 2 access sites. One was a right radial artery and then was a right femoral artery. We used a 7 French EBU to get into the vein graft and a 7 French JR4 for the native right. And then we took a wire through the vein graft into the distal RCA. So we knew that we were in the true lumen at that point. And then we took a whisper and a microcatheter through the native RCA and exchanged for a more aggressive wire called Mongo. And then on the right, you can see here that we knuckled down through a dissection plane across the CTO. And then to enter back into the true lumen, we used a catheter called a Stingray. And this will just be a quick animation of that. So essentially a Stingray is a catheter with a balloon designed to target to re-enter the true lumen from a subintimal space. And it has 2 exit ports that are 180 degrees opposite each other. So you essentially orient your fluoroscopy image so you can visualize one of the exit ports above or below the true lumen of the vessel. And then you advance a sharp wire through that specific exit port to enter the true lumen. So here at the bottom of our wire here is where a catheter is, and there's 2 black knots. I'm sure if you guys can appreciate that, but essentially we oriented so one of the ports be facing above where we are, where the wire is that we know that's in the true lumen. And so you can see the tip of the wire is just coming out of that top port right here. And then here it's advancing through that port and following our other wire that we know to be in the true lumen. And then this confirms that our new wire is in the true lumen and taking those branches, as you can see. So after we were able to enter the true lumen, we exchanged it back for a workhorse wire. We IVIS and then placed 3 stents. The most distal stent was distal to our vein graft anastomosis site and coming back up essentially to the ostium. The patient did really well and she went home the next day. And with that, I'll turn it over to Pratik for our last case.
All right, good morning, everyone. I'll try to keep this brief and quick here. So one of the topics that frequently comes up in patients who refer for catheterization or PCI is renal dysfunction. And so I'm going to briefly talk about some strategies that we use to address this issue in terms of risk of contrast, nephropathy, and AKI. So a case of a 62-year-old male who presented basically has a history of coronary artery disease, had PCI to the flex and LAD, diabetes, has CKD stage 4, baseline creatinine is around 3.5 with a GFR of 20. He's morbidly obese, BMI of 35. He's been having worsening anginal symptoms and which have been more progressive. So he was referred for angiography, which showed a mid-LAD CTO, had a stress test prior to that, which showed anterior ischemia. And so he was evaluated for CABG by CT surgery, and he was quoted a high risk of postoperative hemodialysis. And they quoted him a more than 75% risk of HD and possibly needing dialysis indefinitely. And so with that, the patient wanted to explore percutaneous options, and so he was referred to us. So here's a areocranial still shot of an injection from a microcatheter, and you can see here's a CTO segment right here within a stent segment in the mid-LAD. So I'll come back to this case and how we approached it in a second here. Second case I was going to show is a case of a 66-year-old female with a history of coronary artery disease, had prior PCI to the RCA, ischemic cardiomyopathy, EF of 15-20%. She had stage 4 CKD, baseline creatinine 2.5, GFR 22, and diabetes. She presented with an NSTEMI, underwent coronary angiography, which showed significant RCA in-stent restenosis. And for this diagnostic angiography, 15 cc's of contrast were used, and then she was referred to us for PCI. And this is the shot of the RCA. You can see here, there's a significant in-stent restenosis in the prox to mid RCA. And so, you know, contrast-associated acute kidney injury is obviously of concern in patients with pre-existing renal dysfunction. And there's various definitions out there on contrast-induced nephropathy and various terminology that are used, including contrast-induced AKI. And the most recent and newer term that is preferred is a contrast-associated acute kidney injury, where, you know, there's other factors that play a role in post-procedure renal dysfunction, such as hypotension, atherosclerosis, et cetera. And so the risk factors for renal dysfunction following intervention, prior history of CKD is probably the strongest independent predictor, as shown in the study from the NCDR-CAT PCI registry of over 900,000 patients. And so there are numerous pre-procedure strategies that we can utilize to try and minimize the risk of contrast-associated kidney injury. And probably the most commonly used is isotonic saline infusion, and which is the strategy we use here at Emory. We have a pre-procedure protocol where we hydrate patients with normal saline. All of these other techniques or tools, such as N-acetylcysteine, sodium bicarb, and ischemic preconditioning, we don't really have strong randomized control trial data to support their use. And so, you know, isotonic saline infusion pre and post are probably the most efficacious. And so in terms of specific strategies related to PCI, we can use biplane angiography, which minimizes the number of contrast administration that we do. And there's dedicated systems that are available that minimize the volume of contrast that's administered per injection, such as this divert system that's shown here, which basically, as the name says, diverts about 40% of the contrast volume into a collection system, and the patient gets 60% of the contrast down the coronary. We can use IVUS here, you know, to kind of map the coronaries, basically find your stent landing zone, lesion site, distal landing zone, and use that heavily instead of using angiography for stenting. And then you can see optical coherence tomography is another option here. And specifically, dextran-based OCT has been utilized to minimize the need for contrast. And so in terms of PCI, we have done several cases of zero or low contrast PCI, where we've relied heavily on intravascular imaging with IFR, FFR, pre-procedure and pre and post IVUS imaging, and using our fluoroscopy guides, such as road mapping with guide wires and side branches, and coronary calcification to guide us. And so going back to our case here, you can see we've engaged the right coronary and the left coronary here. This patient has a proximal LAD CTO, proximate LAD CTO, which is an in-stent segment. So we have a microcatheter here in the right coronary, and you can see the septal collaterals from the right coronary to the LAD. We have a microcatheter here in the LAD, and we do a small injection, 1 cc injection here, to outline the septal collaterals. And then we use a very soft wire here to go retrograde from the right coronary artery into the LAD here. You can see this wire making its way up into the LAD. And then at this point, basically, we're gonna use a technique called reverse cart, where we have a wire in the dissection plane anterior coming antegrade, and then a wire that's in the dissection plane retrograde, and we make a connection. And you can see here, basically, our retrograde wire will enter our antegrade equipment. And at this point, we've successfully made a retrograde connection here. And then we IVUS the vessel for imaging to give us appropriate sizing for the stent. And here you can see we have a stent that we're ready to deploy in the LAD. And then we take a 1 cc injection, 1 to 2 cc injection here just to show the distal outflow following stenting. And so this whole, and then here's an example of an IVUS run for this patient. Basically, you can see, what we look for here are our distal stent edge to look for dissections, make sure the stent's well expanded, and then we look at our proximal stent edge to make sure there's no dissection in the proximal edge, and then we look at the ostium to make sure there's no guide catheter induced injury to the vessel. All of this mitigates the need for another contrast injection to evaluate for some of these complications that can potentially happen. And so in this case, we did a retrograde LAD CTO PCI. We used less than 5 cc's of contrast. The patient was discharged home the next day, and then follow-up creatinine was stable at 3.5. So here's a pre and a post image of the LAD here. And then case 2, so this, again, going back to the angiogram here, she has a very tight in-stent restenosis of the proximal RCA. And so we basically staged this intervention following diagnostic angiography. She came back to the cath lab the next day. We direct stented the area based on our reference angiograms, and then we basically performed IVUS instead of angiography to confirm stent placement and optimal stenting expansion, apposition, and look for distal edge dissections and distal and proximal edge dissections. So here you can see the IVUS run, and basically the stent is well expanded, well opposed. There's no dissections distally or proximally in the stent edge, and as well as at the ostium of the coronary. And so basically we did zero contrast, and so surprisingly, the patient came back a year later with repeat chest pain. And so we got a good look at our results a year later. And you can see the stents, the coronary, the stents here that we had placed about a year ago with zero contrast. And there's minimal in-stent restenosis here, maybe 20, 30%, but otherwise the stents patent, and we got excellent results here. And so, contemporary PCI techniques utilizing intracoronary imaging and physiology allow us to perform zero or low contrast PCI, especially in patients with pre-existing renal dysfunction. And pre and post procedure hydration with isotonic saline should be considered in the appropriate clinical setting to minimize the risk of contrast associated acute kidney injury. Thanks, and we'll take any questions or comments.
Pratik, this is Abhi. These were all great cases. Just to comment, it seems the definitions you showed of contrast-induced nephropathy, PCI associated kidney injury, they use a 0.5 milligram per liter cutoff. An increase in 0.5. The cath PCI registry controversially continues to use an increase in 0.3 to define AKI, which is, as many of us know, really not much of a bump in many cases. And so there is that discrepancy. And I've heard for a couple of years now that there have been people advocating for that to increase from 0.3 to 0.5 in the registry. It just hasn't occurred yet. So but that there is that discrepancy there. Any of you who are on interventional councils with the ACC, et cetera, to the extent that you can advocate for some consistency to make the registry 0.5 as well, that would be great.
Great point, Dr. Goyle. Yeah, it's certainly, this is a big kind of, quality metric as well, post PCI. So it's certainly very important for the work we do here, just, in terms of quality metrics as well. So.
Just like to say thanks to Leah, Pratik, Ayman, and Eric. I think it's great presentations. I think they're great cases. It really outlines kind of the complexity that can be done now, with optimal results. It outlines, I think, the collaboration that we have here with the surgeons, to try to truly have a heart team approach. I think the patient-centric discussions happen every day here. And so I think it's a nice just sort of case-based presentations to sort of outline where we are in the PCI spectrum. I think everything you're seeing here is cutting edge, sort of state of the art, and continues to improve. But I thought they were nice presentations. Really appreciate the fellows' efforts.
The preceding program is copyrighted by Emory University.